This conference will now be recorded.
Assalamu alaikum. Good evening, everyone. Can you hear my voice? Is my voice clear? Okay, fine. I'm so glad that you have joined us in this free session. I'm Dr. Mohammad Helmy. I'm a mentor in the mid-exam expert team for Part 1 Mrcog. Today, inshallah, we have a small webinar about the calcium homeostasis. And at the end of the session, of course, I would be pleased to receive your questions. Any question about Part 1, about how to study, how to prepare, and of course, about the topic if you need anything about this topic. Of course, I know that these days are so tough for all of us, that COVID-19 problem worldwide is putting us under stress, and of course, many of us is obligated to postpone many things in his career because of that problem. And of course, there is a lot of confusion about the exam and whether it will be held on time or not. But up till now, like I mentioned in the post, that there are no official statements from the Royal College about Part 1 and Part 2. Only Part 3 has been postponed because it is in May, so of course it's so close, and the problem is still there, and of course it will be so difficult to have an exam in May, but I hope that by July the problem will be under control. We all hope that. So for now, we have to continue preparing and continue studying, and we will pray for the best, inshallah. Of course, one of the important subjects in Part 1, Basic Science, of course, is the physiology subject. Of course, physiology contains a lot of important topics for Part 1 exam. And today, inshallah, we will discuss what's known as the calcium homeostasis. How is calcium regulated in our body? And also, we will go through the calcium related disorders. And of course, this part is very important in Part 1 exam. So what will be the learning objectives of today's session? We will have a look on the serum level and the calcium distribution in our body. Also, we will know the role of calcium in our body. This is very basic, of course. How calcium is absorbed and excreted. How calcium is regulated in our body. What are the interactions which is done between various of hormones and organs to control that balance, to avoid hypocalcemia and hypercalcemia. What are the changes which occur in pregnancy regarding the mother and the fetus? And we will have a quick overview on some disorders related to calcium and the parathyroid hormone. So this will be the main points of our session today. In our body, we have about 1 to 1.5 kilograms of calcium. 99% of this amount is found in bones and the teeth, while only 1% of the total body calcium is found in the body fluids and tissues. So only 1% is found in body fluids and tissues. But when we talk about the plasma calcium or the extracellular calcium, this is the part which is very important for us now. The extracellular calcium accounts for only 0.1% of the total body calcium. This percentage is very important, 0.1%. So we have to differentiate between the extracellular calcium alone and the calcium in cells and body fluids. Cells and body fluids collectively 1% and 0.1% in the plasma only. And this percentage is very important, and it's a very important exam question. This equates to a normal serum concentration of approximately 2.5 millimoles. The normal range is 2.2 to 2.6, but the average is about 2.5 millimoles per liter. This is the extracellular or the plasma calcium. And this part, the extracellular or the plasma calcium, is divided into two forms. The ionized or the free calcium, and this constitute about 45% of the extracellular or the plasma calcium, the ionized form or the free form. And this is the part which is metabolically or biologically active form. So this is the active form of the calcium. While the bound form, which constitutes about 55% of the extracellular calcium, is subdivided into 10% bound to anions like the lactate and phosphate, bicarbonate, and 45% bound to plasma proteins, and this is mainly the albumin. So we have the ionized form, the free form, the active form, and we have the bound form, which is subdivided into 10% bounds to anions, lactate, phosphate, bicarbonate, and 45% bound to plasma proteins, mainly the albumin. And if we look at the normal serum level of calcium, and of course this can vary among different laboratories, but the average, if we measure it by the milligrams per deciliter, it's 9 to 11, which is equivalent to 2.2 to 2.6 millimoles per liter. The ionized is about 5 milligrams per deciliter, while calcium complexed with phosphate and citrate is 1 milligrams per deciliter, 1 milligram per deciliter, and the protein bound calcium is 4 milligrams per deciliter. Actually, in the exam, you don't have to memorize the normal laboratory ranges. At the exam, you will be provided by the normal laboratory values at the first page of the exam booklet. So you don't have to memorize these numbers or these references. You only have to memorize the percentage of the extracellular calcium. That's the most important point in that part. And if we have hypoalbuminemia, of course, we know that 45% of the total calcium is bound to albumin. So if there is hypoalbuminemia, this will result in decrease in the total plasma level. So each 1 gram of albumin will causes a decrease of 0.8 milligram per deciliter. Also, we have to put in our mind that the changes in the blood pH will change the form of the calcium, but not the total level. It will change the form of the ionized or the bound form. Acidosis, for example, will favors the release of the ionized calcium, while alkalosis will favors the binding of calcium and decreasing in the ionized calcium level. In acidosis, for example, the hydrogen ions will compete with the calcium ions for the binding of plasma proteins. So acidosis will increase the concentration of free serum calcium without altering the levels of the total calcium, or without changing the levels of the total calcium. So the biochemistry of people with acidosis therefore seems to be normal, even though they are hypercalcemic, because the active form, the free form or the ionized form, is increased. So in acidosis, the hydrogen ions will compete with the calcium for the plasma proteins. So this will release the calcium from those plasma proteins, and the calcium will be free, will be biologically active. So in acidosis, people, if even though they have normal total calcium level, they are hypercalcemic. Is this part clear?
Sir, one more time. Hello.
Yes.
Sir, one more time, please explain, sir.
Okay.
Acidosis.
Okay. In acidosis, what happens in the blood pH? Okay, the pH is low, okay, and there is a release of the hydrogen ions in excess in the blood, okay. This hydrogen ions will compete with the calcium for the plasma proteins. We know that calcium is bound to plasma proteins, or mainly albumin. So hydrogen will try to attach to these plasma proteins, releasing calcium from its binding to those plasma proteins. So calcium will be free in the blood. When calcium is free or in the ionized form, it is active form, or it is the biologically active form. So even though the total calcium level is the same, but here in acidosis, patient is considered to be hypercalcemic because of the excess amount of the free ionized calcium. Yes, the total amount is not changed, just the form of the calcium is changed. Instead of being bound to plasma proteins, it's now found in the ionized or the free form, which is active. Okay?
Yes, sir. Thank you, sir.
Okay. Welcome. Okay, so that's about the level and the distribution of the calcium. And now, simply, of course, this is very basic science. We know, all of us know, that the calcium has a lot of functions in our body, like bone mineralization, tooth formation, muscle contraction. It's an enzyme cofactor, act also as a intracellular messenger. It helps in the stabilization of the membrane potentials and regulation of the cellular division, proliferation, and apoptosis. Of course, this is very clear for all of us, and that's a very basic knowledge. The recommended daily allowance, or the UK reference of calcium intake. What's important to us to know that the demands of calcium increase in pregnancy and lactating women. In the lactating woman, especially in lactation, it needs about 1,250 milligrams per day of regular calcium intake. As we know later in absorption, that the calcium is not absorbed efficiently from the intestinal tract, about only 20 to 30%. So that's why we give high amount in as a nutrition or in diet. So because only 20 to 30% will only be absorbed from the intestinal tract. Now let's talk about the most important part, which is the absorption and the regulation of the calcium. Absorption of calcium from the diet is relatively inefficient, with only 20 to 30% will be absorbed from the dietary intake. So only 20 to 30% of the dietary intake will be taken up by the human body. And actually, the absorption is different according to different situation. For example, according to the age, it's increased in children and decreased with advanced age. Also according to the intestinal function. If there is malfunction of the intestine due to malabsorption disorder or there is any GIT problem, of course, the absorption will be decreased. Also according to the diet. For example, lactose will increase the absorption of the calcium, while oxalates and phytates will decrease the absorption because it binds to the ingested calcium. Also, vitamin D availability. Vitamin D enhances the absorption of the calcium from the intestine. So if there is vitamin D deficiency, there will be malabsorption of the calcium. Calcium absorption can occur throughout the GIT, but the majority of calcium is absorbed in the small intestine, especially in the first part and the second part of the duodenum. So 60 to 70% of all ingested calcium will be absorbed in the small intestine, mainly the first and the second part of the duodenum. And the calcium is absorbed against concentration gradient and requires energy and a carrier protein. This is very important to know that calcium is absorbed against concentration gradient, and it will require energy and a carrier protein for the process of absorption. If we look at this figure, we have two routes of calcium absorption. If you consider that this is the cell, intestinal cell, okay, we have two routes. One route is called the transcellular route across the cell, and the other route is called the paracellular route in between the cells. Here at the transcellular route or the intracellular route, the calcium goes into the cell via what's called the epithelial calcium channel. It's called TRPV6. This is the name of this channel, the epithelial calcium channel, and then goes through this channel into inside the cell to bind to calcium binding protein, and then this is called endocytosis, the endocytosis of the calcium inside the cell. Then after binding to this calcium binding protein, it will pass to the circulation by a process of exocytosis or exocytosis by what's called plasma membrane calcium ATPase channel. So intracellularly, it goes or endocytosis inside the cell by what's called the endocytosis by a TRPV6 calcium channel, and this bind to calcium binding protein, and then go to the circulation via exocytosis by what's called plasma membrane calcium ATPase channel. This is one route. The second route is paracellular in between the cells, and this only need a calcium binding protein. So these are the two ways for calcium absorption or for calcium to be absorbed through the intestinal tract. This is regarding the excretion. We have to know that all of the free ionized calcium and the calcium bound to anions is filtered by the glomerulus, and most of the filtered calcium, 99% of the filtered calcium, is reabsorbed. Also, reabsorption occurs by two routes, the paracellular route and the transcellular route. And also the transcellular or the intracellular requires the presence of epithelial calcium channel, but this time it's called TRPV5, not 6, like the intestinal channel. The intestinal channel called TRPV6, while the glomerulus channel here it's called TRPV5. Okay, so also reabsorption of calcium occurs via two routes, the paracellular and transcellular route. And most of the filtered calcium, 99%, is reabsorbed. And the majority of the calcium is reabsorbed in the proximal convoluted tubules. The majority of calcium is reabsorbed in the proximal convoluted tubules. So how the balance of calcium is controlled in our body? The calcium balance depends on either the difference between the amount of calcium absorbed and the amount excreted, and the balance between the amount buffered in the bone and the concentration in the extracellular fluid. In general, children have a positive calcium balance. And in adults, the balance should be neutral. The input equals the output. And in the postmenopausal woman and the elderly people, usually they have a negative calcium balance. A disruption in the calcium homeostasis will result in either hypocalcemia or hypercalcemia. So any change in the calcium level will either result in hypocalcemia or hypercalcemia. And of course, any change in the calcium level will affect also the phosphate status. Okay, now we have different hormones and different organs which interact together to regulate this balance. These hormones are the vitamin D, the parathyroid hormone, and the calcitonin. And the organs are the intestine, thyroid, parathyroid glands, kidneys, and bone. And we will talk about the main organ, which is the parathyroid gland. These glands are 4 glands located on the posterior of the thyroid gland. Their origin are from the pharyngeal pouches. Of course, this part is discussed in details in embryology, but we have the pharyngeal pouches. The superior glands are originating from the dorsal portion of the 3rd pharyngeal pouch, and the inferior gland is originating from the superior portion of the 4th pharyngeal pouch. This is the embryology of the parathyroid gland. They are small gland. Their weight is less than 40 milligram each. They are supplied by branches of the inferior thyroid arteries. This is a question in anatomy. They are supplied by branches of the inferior thyroid arteries, and they contain 2 types of cells, the oxyphil cells and the chief cells. These type of cells, the chief cells, are the cells which synthesize and secrete the parathyroid hormone. And this is a very important exam question. The chief cells are the cells responsible for synthesis and secretion of the parathyroid hormone. Parathyroid hormone is a peptide hormone, contains about 84 amino acids. The origin of the parathyroid hormone, or the precursor of the parathyroid hormone, is what's called the pro-parathyroid hormone. It is 115 amino acid compound. undergoes some cleavage processes until giving us the parathyroid hormone containing about 84 amino acids. They are secreted by the chief cells of the parathyroid gland. The parathyroid hormone acts on types of cellular surface receptor or cell surface receptor called G protein coupled receptor. This is the cell. These are cell surface receptors called G protein coupled receptor. And of course, there are various types of cell receptors. Of course, this part, the cell receptors and the second messengers, all this is parts or topics of biochemistry. Of course, we cannot give it in details now, but that's the parathyroid hormone will act on this G protein surface receptors to stimulate a secondary messenger which is called cyclic AMP. Then cyclic AMP will go to the cell nucleus or the hereditary material or the chromosomes or so on to activate certain genes to stimulate the cell to do its actions. Of course, this part will be discussed in details in biochemistry, but this is the mechanism by which the parathyroid hormone acts. It acts on type of receptor called G protein receptor. The stimulation of such a receptor will activate a second messenger called cyclic AMP. And the release of the parathyroid hormone is initiated by what's called the calcium sensing receptor in response to hypocalcemia. In the parathyroid gland, there are types of receptor called calcium sensing receptor. This receptor respond to hypocalcemia. If there is some sort of hypocalcemia, they will be activated to stimulate the parathyroid gland to synthesize and release parathyroid hormone. So, parathyroid hormone is a peptide molecule containing 84 amino acids secreted from the cells. Yes. Is there any question? Okay. So, the parathyroid hormone is a peptide hormone, 84 amino acid, released from the chief cells of the parathyroid gland, act on G protein coupled receptors, and it is released by stimulation of what's called the calcium sensing receptor in the parathyroid gland in response to hypocalcemia. What are the actions of parathyroid hormone? The first thing is that it stimulates bone resorption. Bone resorption. So it will release the calcium and phosphate from bone. So it will cause bone resorption and release of calcium and phosphate from bone. Also, it binds to parathyroid hormone receptors on the osteoblasts, resulting in what's called osteoblast-mediated activation of osteoclast differentiation. We know that the cells which build up the bone are called the osteoblast, and those which make resorption of the bone to release calcium and phosphate are the osteoclast. So it will bind to some receptors on the osteoblast to activate the osteoclast differentiation, and this will enhance bone resorption and release of calcium and phosphate from bone. Also, some in vitro studies have shown that parathyroid hormone inhibit collagen synthesis by activation of the osteoblasts. So it causes bone resorption by activation of osteoclast differentiation, and it inhibits collagen synthesis by parathyroid hormone activated osteoblasts. These are the actions of parathyroid hormone on the bone. But What about the kidneys? In the kidneys, it increases the calcium reabsorption, and also it inhibits the reabsorption of phosphate and increase the phosphate excretion. So in the kidneys, it enhances calcium reabsorption and promotes phosphate excretion. This is very important to know. And also in the kidneys, it helps in the activation of vitamin D by activating the activity of the enzyme 1-alpha hydroxylase enzyme, which is the final step of the activation of vitamin D in the kidneys, as will be shown later when we discuss the vitamin D. So parathyroid hormone is released in response to hypocalcemia. So its actions must be directed towards rising up the level of the calcium in the serum. So it will stimulate the bone resorption to release calcium and phosphate from the bone. And in the kidneys, it will stimulate calcium reabsorption and phosphate excretion and activation of vitamin D. And also vitamin D later on will stimulate more calcium absorption from the intestine. So these are the actions of the parathyroid hormone. This is a note to be known that there is something called the parathyroid hormone related peptide. The parathyroid hormone related peptide. This hormone related peptide is somehow similar to the parathyroid hormone. The first 34 amino acid of both molecules are nearly the same. And the action of the parathyroid hormone related peptide is somehow mimics the parathyroid hormone action, but it's not released from the parathyroid gland. It's released from cancer cells, and also it may be responsible for the hypercalcemia associated with malignancy. Physiological functions are not completely understood, but it regulates the chondrocyte development and endochondral bone formation. Also, it has a role in the placental calcium transport and fetal development. And when we measure the parathyroid hormone-related peptide concentration, it will be normal in cases of hyperparathyroidism, because as we have mentioned that it's not released from the parathyroid gland, but secreted from other cells, and usually it's found in malignant hypercalcemia and from cancer cells. Also, parathyroid hormone related peptide does not increase the levels of activin vitamin D or the calcitriol like the parathyroid hormone. So they are secreted from different origins, but they have the same functions. Nearly they have the same functions like each other. Regarding the calcium homeostasis, also we have the vitamin D, which is very important in this process and helps in the absorption of the calcium from the intestine or the GIT. First, of course, vitamin D is synthesized by various process until activation to the active form, which is called the calcitriol. This is the active form of vitamin D, and this is also a very important exam question. First, we have what's called the 7-dehydrocholesterol in the keratinocytes of the skin. When exposed to the sunlight, it will be transformed to what's called vitamin D3, which is called the cholecalciferol. Then the cholecalciferol will be activated in the liver by an enzyme called 25-hydroxylase to form what's called the calcidiol or the 25-cholecalciferol. And then another step of activation in the kidneys by the enzyme called 1-alpha hydroxylase to form what's called 1,25-dihydrocholecalciferol or what's called the calcitriol. and this is the active form of vitamin D. And this form of vitamin D is metabolized, inactivated, and excreted by an enzyme called 24-hydroxylase enzyme. So we have the sunlight, which transfers the dehydrocholesterol into cholecalciferol. Then by activation in the liver by the 25-hydroxylase enzyme, it will form calcidiol, and then by the 1-alpha hydroxylase enzyme, it will form the calcitriol, which is the metabolic active form of vitamin D. So we have different metabolites of vitamin D. The metabolite that's considered to be the biologically active molecule is what's called 1-alpha 25-dihydroxyvitamin D3, or what's called the calcitriol. And the major circulating form of vitamin D, which is measured clinically, is the calcidiol, or the 25-hydroxyvitamin D3, or 25-hydroxycholecalciferol. Okay. Are things clear up to now? Okay. Vitamin D act on another type of receptors called nuclear receptor. Nuclear receptor, not a cell surface receptor. That's the difference between the parathyroid hormone and the vitamin D. Parathyroid act on cell surface receptors, while the vitamin D act on nuclear receptors, the receptors found in the nucleus or on the nucleus. It is transferred inside the cell by a glycoprotein called megalin. This is a large glycoprotein that has been identified as the membrane transporter for the calcidiol and calcitriol inside the cell. Then after they go inside the cell, they bind to their nuclear receptor inside the cell to activate the genes and regulate the protein expression after that. So that's the vitamin D receptor and vitamin D signaling process. What are the actions of vitamin D? Vitamin D will increase the serum level of calcium and phosphate, mainly by increasing their intestinal absorption and increasing the kidney reabsorption. Vitamin D is required also for normal bone remodeling. It regulates the osteoblast activity to increase the bone mass and calcification, and also promote the osteoclast differentiation and promoting bone resorption. Vitamin D is also required for the chondrocyte development. So the main action of vitamin D is acting on the intestinal tract and promote absorption of both calcium and phosphate, and also increase their kidney reabsorption. So that is the first difference between vitamin D and parathyroid hormone. Parathyroid hormone, it doesn't act upon the GIT. The second thing is that vitamin D promote the reabsorption of both calcium and phosphate, while the parathyroid hormone promote only the absorption of calcium, while it promotes excretion of phosphate. The vitamin D regulate both the osteoblast activity and osteoclast differentiation. So it makes like a state of balance between the osteoblast and the osteoclast. On the other hand, parathyroid hormone act only in the direction of bone resorption. It activates osteoclast to promote bone resorption. Vitamin D is also required for chondrocyte development and other roles related to the immune system, modulation of inflammation. Also, it has an anti-proliferative and pro-differentiation properties, and some studies has shown that vitamin D helps in the apoptosis and impairing in the progression of the cell cycle of many cancer cells. So these are other rules of the vitamin D in the body related to the immune system, the process of inflammation, and the apoptosis or the death of some cancer cells. Vitamin D deficiency may be due to nutritional origin, poor diet or malabsorption, failure to synthesize vitamin D, liver or kidney disease, so there is insufficient vitamin D activation, or ultraviolet light deficiency or lack of sunlight. And of course, vitamin D deficiency will result in defective bone mineralization and growth plate abnormalities. It will lead to rickets in children and osteomalacia in adults. The third hormone is the calcitonin. Calcitonin is also a peptide hormone. It binds also to a G protein coupled receptor and activates cyclic AMP signaling like the parathyroid hormone. And it's released from the thyroid C cells in response to a raised serum calcium. So here calcitonin acts as a counter-regulatory to the parathyroid hormone. It acts in the opposite direction of parathyroid hormone. Here, calcitonin is released in response to a raised serum calcium, and it will act in the direction of lowering this serum calcium level. And it's released from what's called the thyroid C cells. So it's released from the thyroid gland. And as we have mentioned, the parathyroid hormone related peptide, also we have what's called the calcitonin gene related peptide. But here, the calcitonin gene related peptide is released from the same gene which released the calcitonin, but they have different actions. We have mentioned in the parathyroid hormone that parathyroid hormone and parathyroid hormone related peptide, they are released from different origins, but nearly they have the same actions. But here, calcitonin gene and calcitonin related peptide, they are released from the same cells or from the same gene, but they have different actions. The calcitonin gene related peptide is a potent vasodilator and also functions as a neurotransmitter. Of course, this part is not important, but just to mention in case you heard about what's called the calcitonin gene related peptide. So you know that it's released from the same cells or the same gene, but it has a different action from calcitonin in regulation of the calcium homeostasis. So the calcitonin actions are antagonistic to parathyroid hormone and vitamin D, as it inhibits the calcium absorption by the intestine. It inhibits the reabsorption of phosphate and calcium from the kidneys, and it acts on the osteoclast, causing them to shrink and reduce bone resorption, and so prevent the release of calcium and phosphate. And they stimulate the osteoblast to sequester the calcium inside the bone. So all of the actions of calcitonin are in the direction of lowering the levels of calcium in the blood. So it inhibits calcium absorption from the intestine, inhibits calcium reabsorption from the kidneys, inhibits bone resorption by the osteoclast, and stimulate the osteoblast to sequester calcium in bone. So if we want to summarize that part, the regulation of the calcium level. Here we have, if we have low calcium level in the blood, this will be detected by receptors in the parathyroid gland called the calcium sensing receptor. And in response to that, the parathyroid hormone will be released. So if there is low calcium, this will stimulate the calcium sensing receptors in the parathyroid gland, releasing parathyroid hormone. What will be the actions of parathyroid hormone? The first thing, it will act on the bone to stimulate bone resorption and calcium release. That's the first action. Then in the kidney, parathyroid hormone will promote the reabsorption of calcium and excretion of phosphate, and it also increases the activity of the 1-alpha hydroxylase enzyme to convert the calcidiol into the active metabolite calcitriol. Okay, these are the actions of parathyroid hormone. And now we have the active form, the calcitriol. What will the calcitriol do to help in that part? First, it increases the bone turnover and also increase the absorption of the calcium from the intestine and calcium and phosphate reabsorption in the kidney, resulting an increase in the serum calcium concentration. So calcitriol will also promote bone resorption, stimulate absorption of calcium from intestine, and enhance the calcium and phosphate reabsorption in the kidney, resulting in an increase in the serum calcium concentration. After calcium level being normalized, calcium and the calcitriol, or the active form of vitamin D3, will provide a negative feedback to the parathyroid gland to inhibit further secretion of the parathyroid hormone. So after they finish their role, calcium and the calcitriol will make a negative feedback on the parathyroid gland to inhibit any further secretion of the parathyroid hormone. In response to hypercalcemia or increase the calcium concentration, calcitonin will be produced from the thyroid gland. It will inhibit renal calcium and phosphate reabsorption and osteoclastic bone resorption, and also it will inhibit the intestinal absorption of calcium to lower the level of the calcium in the blood. There is another mediator which is called the fibroblast growth factor 23. The fibroblast growth factor 23. What is the role of this mediator? This is called a phosphaturic hormone. What's meant by phosphaturic hormone? That it leads to excretion of phosphate in the urine. This mediator or this hormone is released from the bone cells, mainly the osteocytes, in response to stimulation by the calcitriol, and seeks to limit the calcitriol-induced increase in the serum phosphate concentration. We know that the calcitriol enhances the calcium and phosphate absorption from the intestine and reabsorption in the kidneys. So if this occurs without any antagonistic action, the level of phosphate will increase, leading to hyperphosphatemia. But this is controlled by what's called the fibroblast growth factor, which is released from the osteocyte to make some sort of diuresis to that excess phosphate in the urine and leading to release of or excretion of this phosphate through the kidneys. So we can say that it causes some balance to limit the calcitriol-induced increase in the serum phosphate concentration. So is this part clear? Okay, fine. So this table is a summarized table for all what we have mentioned, the role of the kidneys, bone, parathyroid, GIT, thyroid glands in the process of calcium balance. By the way, this table is from the Essential Revision Guide book. And also this table, the second table, which also shows a summary in the interaction between the different hormones, the parathyroid hormone, the vitamin D, and the calcitonin in the process of regulation of calcium level. The type of the receptor, the site of the synthesis, the stimulus of secretion, the actions, and the result of the secretion. See here that the difference between the parathyroid hormone and vitamin D. Parathyroid hormone lead to increase in the serum calcium while decrease in the serum phosphate. And by the way, this is a very important exam question. It came before in the exam. While vitamin D will increase both serum calcium and serum phosphate. Calcitonin will lead to decrease in the serum calcium. Phosphate, of course, this is not the main cornerstone of the session, but we know that phosphate is highly related to calcium, and the reabsorption and the remodeling process of the bone will affect both calcium and phosphate. Absorption of phosphate from the diet is efficient, unlike the calcium. About 80% of the ingested phosphate being absorbed, and the phosphate is required for formation of many compounds in the body, like the ATP, creatine phosphate, second messengers like the cyclic AMP, inositol phosphates, and the phosphorylation of many enzymes. It's a component of DNA, RNA, and the membrane phospholipids. This is very important. Actually, this is a very important topic or part in the biochemistry about the membrane phospholipids and the inositol phosphates, as they are part of secondary messengers. But of course, this is discussed in details in biochemistry. Approximately 86% of phosphate is stored in the bone, and only very low part is found extracellularly from 0.03 to 0.1%. It's important to remember that the kidney is the only organ which is capable of excreting phosphate. So any person with chronic kidney disease is at risk of hyperphosphatemia due to the inability to excrete phosphate. So what about the pregnancy? And this part is very important. Actually, physiology and part 1 MRCG is talking mainly about changes happening in pregnancy in the various body systems. So changes which happen in pregnancy is very important to be known in each system in physiology. We know that pregnancy and lactations are periods of increased calcium demands or requirements. That's very important for the growth of the fetal tissue and also the production of milk, and that's act as a huge drain or burden on the mother's mineral resource. And to cope with these requirements, there are some sort of changes which found to happen in the pregnant lady to help these requirements needed by the fetus. Like they found that the parathyroid hormone is usually it's normal, or there is some sort of decrease in the level of parathyroid hormone, but that's can be balanced by a huge increase of the vitamin D levels, because vitamin D is required for absorption from the intestine. So they found that in pregnancy there is increased level of vitamin D and also increase the level of calcitonin. These changes occur early in pregnancy for the preparation of the fetal requirement. So in pregnancy, we have normal or slightly decreased parathyroid hormone level, increase in the calcitonin, and increase in the vitamin D to promote absorption of the calcium from the intestine. The fetus itself contains about 20 to 30 grams of calcium, and it's considered hypercalcemic compared with the mother. Why it's considered hypercalcemic? Because the concentration of the calcium in the fetal circulation is higher than the concentration of calcium in the maternal circulation. They found that the ratio is 1.4 to 1 from the fetus to the mother. That's why when calcium is transferred from the mother to the fetus, it's considered against concentration gradient, because here the concentration of calcium is higher than the concentration of calcium in the mother. So this will require energy and transport protein. So it's a form of active transport. Calcium is transported by carrier protein and energy from the mother to the fetus. Most of the calcium is accumulation in the fetus will occur in the third trimester when ossification occurs. So, to summarize this part, the fetus contains higher concentration of calcium. I'm talking about concentration, and of course, I'm not talking about the total amount. Of course, the total amount in the mother is higher, but I'm talking about the concentration of the calcium inside the circulation. The ratio between the amount of calcium and the blood volume will lead to a higher concentration of calcium here inside the fetal circulation. So the fetus is considered hypercalcemic in comparison to the maternal circulation. That's why calcium, when transferred from the mother to the fetus, it's against concentration gradient and needs a carrier protein and energy, or what's called active transport. And also most of this calcium will be accumulated in the fetus in the third trimester when ossification occurs. Also, the fetus had the ability to synthesize parathyroid hormone by week 12 of gestation. And this hormone will remain low for the first 2 to 3 days postpartum, in the fetus, of course. And many fetal tissues produce the parathyroid hormone-related peptide, which plays a role in the regulation of placental calcium transport, as we mentioned before. Birth, the newborn baby has low parathyroid hormone level and high calcitonin level. So, the mother, the free ionized calcium remain the same, but pregnancy is a hypocalcemic state due to the active transport of calcium to the fetus, increase the renal loss due to increased the glomerular filtration rate, decrease in the serum albumin, and increase in the calcitriol and calcitonin. While the fetus contains 20 to 30 grams of calcium, it's hypercalcemic compared to the mother. Calcium and phosphate are actively transported. Ossification occurs in the third trimester. The fetus produces parathyroid hormone from 12 weeks. I can say that this slide is very important. These are many exam questions. This the summary of the changes which happen in pregnancy in the mother and the fetus, and we can say that this is the most important part in physiology in general, to know what changes happen in pregnancy. Do you have any question in this part? Okay, great. Now let's talk about the disorders related to the calcium and parathyroid hormone quickly, of course. And we have the most famous disorder here for the parathyroid hormone, which is the hyperparathyroidism. Hyperparathyroidism. And we have three forms of hyperparathyroidism: the primary, secondary, and tertiary. Hyperparathyroidism results from excess synthesis and release of parathyroid hormone, and this is associated with increase in the bone resorption. Increase in the bone resorption. So what is the difference between primary, secondary, and tertiary? Primary hyperparathyroidism, usually due to a defect in the parathyroid gland, mainly benign tumor or gland hyperplasia, or maybe rarely malignant tumor. This change in the parathyroid gland will lead to increase in the synthesis and release of parathyroid hormone. So the increase in the level of parathyroid hormone will be also associated with increase in the level of calcitriol and decrease in the level of phosphate. And of course, at the end, it will lead to hypercalcemia. Primary hyperparathyroidism is one of the frequent causes of hypercalcemia, and it's considered generally in the endocrinology or in the endocrine disorder as the third most common endocrine disorder after diabetes and after hyperthyroidism. And here, this is a very important point to put in our mind, that the increase in the level of the calcitriol and the decrease in the level of phosphate indicates that the kidneys are functioning. That's how to differentiate between primary hyperparathyroidism and secondary hyperparathyroidism, as we are going to know now. So in primary hyperparathyroidism, there is increase in the parathyroid hormone due to gland hyperplasia or benign tumor. This will lead to increase in calcitriol, and the parathyroid hormone will increase. It will lead to increase the excretion of phosphate from the kidneys, so the level of phosphate will decrease. Now, when we talk about the secondary hyperparathyroidism, here the secondary hyperparathyroidism is due to a defect in the feedback control. Most commonly, the primary defect will be in the kidneys here. And the secondary hyperparathyroidism is usually due to chronic kidney disease. Why? Because here the kidney is unable to respond to the normally to the parathyroid hormone. So the renal reabsorption of calcium will not stimulated, vitamin D activation will not promoted, so calcium will not be reabsorbed from the kidneys or be absorbed from the intestine due to vitamin D deficiency, because vitamin D is not activated. So the only way to increase the calcium level is the bone here. So bone resorption will increase, leading to osteomalacia. But also this bone resorption or osteomalacia will not be sufficient to normalize the level of calcium. So there will be no negative feedback on the parathyroid hormone. We know that when the calcium level normalize and the calcitriol are found, it will lead to a negative feedback on the parathyroid hormone. But here in this situation, calcium is not normal. Calcitriol also is not activated. So there is no negative feedback mechanism on the parathyroid gland. Still, there is hypocalcemia. So the parathyroid gland will continue to secrete parathyroid hormone without stoppage, leading to hyperplasia of the gland and what's called secondary hyperparathyroidism. And the tertiary hyperparathyroidism means that there is end-stage renal disease, end-stage renal disease. So that's the difference between primary, secondary, and tertiary hyperparathyroidism. Hypercalcemia means that the sorry, I didn't see the chat. Someone is saying no, sir. What part is not clear? Can you tell me? You can open your mic and talk, okay? No problem. Does anyone has any question about that part before proceeding? Okay. Okay, okay. Okay, please, when you want to interact, open your mic and talk to me, okay? Because I don't see the chat a lot while I'm giving the session. Okay, so you can open your mic, and if you have any question, you can talk to me. Okay, so high calcium level in the blood, more than 2.6 millimoles per liter is considered hypercalcemia. So levels more than 2.6 millimoles is considered hypercalcemia. What are the causes of hypercalcemia? Of course, the most important and the most common cause is the hyperparathyroidism, whether primary or secondary, and so on. So also there are some diseases like tuberculosis and sarcoidosis. These diseases are associated with increase in the vitamin D levels. So there will be increase in the absorption of the calcium from the intestine, leading to hypercalcemia. Some cancers like lung cancer, breast cancer also is associated with hypercalcemia. Many diuretics and excessive intake of vitamin D or calcium, hyperthyroidism, being bedridden or immobilized, Paget disease of the bone, multiple myeloma, all these are diseases associated with hypercalcemia. This diagram shows the most important causes. Here, the granulomatous disease like TB, fungal disease, sarcoidosis, leading to vitamin D intoxication. So it will lead to increase here, like see here, stimulation of the absorption of calcium. The immobilization, malignant tumors, hyperthyroidism, increase the bone resorption. So this also will increase the calcium level. We have some disorders like what's called familial hypercalcemia or the thiazide diuretics. These will leading to reabsorption of calcium from the kidneys. Also, the hyperparathyroidism will promote reabsorption of the calcium from the kidneys and bone resorption, and also will lead to increase in the calcium level. So this diagram shows the most important causes of hypercalcemia. The clinical picture of hypercalcemia, it's very famous. What's called bones, stones, groans, and psychic moans. These are the signs or symptoms of hypercalcemia. The moans include weakness, tiredness, confusion, depression, reflexes are sluggish, and even there is coma. Regarding the cardiovascular system, we have short QT interval in the ECG, and fatal cardiac arrhythmias may be seen. Also, renal stones can occur due to increased urinary calcium levels, polyuria, dehydration, and renal failure, ectopic calcification secondary to hypercalcemia in the heart, pancreas, uterus, and the liver. Also, we have abdominal pain, anorexia, constipation, and bones are painful and fragile due to excessive bone resorption. So these are the symptoms and signs of the hypercalcemia. We have the weakness, tiredness, confusion, coma, short QT interval in the ECG and cardiac arrhythmias. We have renal stones, polyuria, dehydration, ectopic calcification, bone resorption, and abdominal groans in the form of abdominal pain, anorexia, vomiting, constipation, and so on. These are the clinical picture of hypercalcemia. In the past, complications such as bone loss, fractures, kidney stones, kidney failure, hypertension, cardiac arrhythmias were commonly found as a result of long-standing untreated high calcium levels. But of course, these are now rarely seen because of the blood tests, which lead to early preventive measures. On the other hand, hypocalcemia is defined as total serum calcium less than 8.8 milligrams per deciliter or less than 2.2 millimoles, or serum ionized calcium, talking about the ionized, not the total level, concentration less than 4.7 milligrams per deciliter or less than 1.17 millimoles per liter. This is hypocalcemia. The most common cause also of hypocalcemia is hypoparathyroidism. And hypoparathyroidism can be inherited or can be a result of surgical removal of the thyroid gland or cancer in the head and the neck, leading to damage of the parathyroid gland. So any damage of the parathyroid gland or surgical removal or can be inherited will lead to decrease in the senses and level of parathyroid hormone, and this will lead to hypocalcemia at the end. Also, other causes of hypocalcemia include vitamin D deficiency or low calcium diet, acute pancreatitis. Some medications like phenytoin, phenobarbital, and rifampicin are associated with decreased calcium absorption. Also, diarrhea, constipation, or malabsorption of the calcium from the intestinal tract, and massive blood transfusion also can lead to hypocalcemia. So that's why when we give blood transfusion, we give calcium blood transfusion. Of course, hypocalcemia is famous with clinical pictures like muscle stiffness, muscle spasm, paresthesia, numbness, and tingling. Also, it is associated with a very famous sign, which is called Chauvistic's sign, which when we tap over the facial nerve, it will lead to a facial twitch. And of course, in severe cases, it will lead to tetany or carpopedal spasm or the Trousseau sign. Also, it lead to arrhythmia, prolonged QT interval on ECG, and also in severe cases, it can lead to seizures and laryngospasm. All these are the clinical pictures of hypocalcemia. By this, we come to the end of the calcium homeostasis session. This part is very important. Of course, we will give you a link to the recording of that session because mostly it will be uploaded on our YouTube channel. Also, I'm going to give you two links of two sessions given before in the before the previous exams, one for the ABG and one for the illustration. And these sessions are found in our YouTube channel. You can listen to them. Thank you for joining us. If you have any question related to this part or related to anything related to MRCG or any queries, please, I will be pleased to listen to you.
Thank you.
You are welcome. Dr. Angie, when will you conduct ABG? Actually, we conducted it before the previous batch or the previous exam. It's already found in our YouTube channel. I'm going to share the link with you in the part 1 guide group. I'm going to share the link of the ABG, the link of urodynamics, and the link of this session when it is uploaded in our YouTube channel. Okay. Thank you, Dr. Maliha, for your kind words. Thank you so much. Thank you, Dr. Angie. Thank you so much. Thank you so much, Dr. Saman. Thank you. Dr. Fatima, thank you. You are welcome. Thank you, Dr. Vijaya. Actually, before we close the session, my recommendation to you to continue preparing, to continue studying, work and act as if there is no problems at all. Inshallah, everything will be okay soon. We hope, inshallah. And if there is any problems regarding the exam or any delay or so on, you will not lose anything. You will consider to have an early preparation, so it's not a problem at all to study and do your best until things are clear from the Royal College side. Which is the best book for physiology? Actually, I recommend to have a look at the Oxford Revision Notes. Oxford Revision Notes, the good thing of that book is that it will give you like a frame or the outlines of the topics that you have to cover. And some topics you can also have a look at Essential Revision Guide book. It contains also some good information. By the way, regarding the calcium homeostasis, for example, I collected this session from 3 different books, the Philip Bennett book and the Essential Revision Guide and the Oxford Revision Notes. So I recommend that this should be your way in studying, that you have Oxford Revision Notes as the core book or the main book, and then you can have a quick look on a book like Essential Revision Guide or Philip Bennett if you wish. And if you want to add more notes to your Oxford Revision Notes, of course, it will help you. The exam is now different than before. Now it depends on having good concept and good basic knowledge, not like before, just memorizing some questions and then you will pass. No, of course, in the last 2 years, the Royal College has made the exam more tough and more difficult. So you have to clear your concept. You have to collect as much as basic knowledge as you can. Dr. Bahouti, I know that this book is also one of the good books. Of course, I didn't read it, honestly, but I know that Dr. Bahouti notes are also good. But that's from other colleagues' opinion, not mine, because I didn't read that book actually. But if you want to have this book and look at it also, it will be, of course, good. But I don't want you to, be confused and, put a lot of burden on you while you are studying. Just have 2 or 1 or 2 books like Oxford Notes and Essential Revision Guide, maybe, or if you want to have a look on Philip Bennett or any other third book according to your time and the availability, and then focus on answering many questions from the books and online question banks, and this will add more information to you. You are most welcome. It's my pleasure. It's my pleasure. Thank you so much. It's my pleasure. And anything you need in the Part 1 guide group, please post and just mention me or Dr. Zaib or any other member of the mid exam. And of course, we will answer you immediately. Also, Dr. Zaib will give you another session, I think, on Thursday. And it will be also on hepatitis B serology interpretation, how to interpret the serology of hepatitis B virus. I think it will be on Thursday. And of course, we will announce about this session, inshallah, these days. Okay, thank you so much. I wish you good night, and please stay safe and protect yourselves and your families, and pray a lot that God help us these days to pass this crisis of the COVID-19. And I wish you safe days, inshallah, these days. Okay. Good night.